Philip alluded to David taking that group of Australian parliamentarians to Myanmar and Thailand last year, but David was unstinting in coming along on site visits that we organised with members of parliament from across the parliament, and would spend 4 or 5 days. These were long and gruelling, often long but very interesting discussions were had with members of parliament, and David would always be at the front of persuading, talking, cajoling, explaining in effective and simple ways to members of parliament so that they could go back and be much better informed about what he was doing, but what was very imperative in generating funding and resources to assist people in our region and so on. Professor Matthew Law is head of biostatistics and databases program at the Kirby Institute. When the federal government funded in Checker all those years ago, the most compelling reason, of course, was that without statistics and analysis, you couldn't possibly have good policy outcomes. And HIV was an emergency. It wasn't quite apparent at that time that you needed a long-term statistical basis for investigating what we thought might be here today and gone tomorrow, how wrong we were, but how right it was for Ron and David to make that critical assessment and understanding that we needed a firm epidemiological statistical base, and without that we could never have implemented and radical and bold policies. So with that, Matthew has a long history, involvement, mathematical epidemiology and so on, but is to talk to us today about the HATI project in Indonesia, HIV Test and Treat Initiative in Indonesia. And I want to say that Dr. Nafsia Mboy, who is a very close friend of David's, former Health Minister of Indonesia, she has sent to Dorrie and the family in Kirby her sincere condolences, and she understands and wants to say how wonderful David's contribution was in Indonesia. He was always there and always willing to bring forward the next generation of Indonesian researchers, about which we will hear from Matthew. Thank you.
Thank you. And it's a pleasure to be able to present this on behalf of the HATI team. HATI is, of course, an acronym, HIV OAL, Early Testing and Treatment Indonesia. HATI also is a Bahasa Indonesia word that means liver, but also refers to the seat of emotion, so something like heart and soul. So one of the better study acronyms, I think. So as part of this talk, we were encouraged to give an anecdote perhaps about how David worked, and I thought what I'd do in that respect was describe how HATI came about. And the starting point was this is the Indonesian treatment cascade in 2014. And when David first started talking to me about this, it was actually a bit before this, probably end of 2012. As you can see, treatment rates are low in Indonesia. And at the same time, it's concentrated in the key populations. So I think David saw an opportunity perhaps to do some work here. I was talking to Oscar Baranecki, who was the WHO chap in Indonesia at the time. And as a first step, he got Amit Achra and I to flesh out a skeleton test and treat project. That was in early 2013. And then David organised this fairly elaborate visit to Jakarta in October 2013. So David, Amit and I went up, and Bill Botel was there for a couple of days as well. And we visited WHO, Ministry of Health, National AIDS Commission. We went to DFAT, AusAid, we went to USAID, we met with the Australian AIDS Ambassador, James Gilling, at the time. We met a representative of the Indonesian Health Minister, we went to various clinics, hospitals, labs. We drove up the road to Bandung and met Rudy Wiksasana and his team for a day. And we had this kind of sales pitch we did where I talked a bit about what research we'd done up in the Asia region. Amit described this skeleton project that we'd sort of half developed, and we had we'd have a question and answer session with the various people. And we were there about a week, and I must admit I came back from it slightly dispirited. There was some interest, some of the sites were very enthusiastic, But I couldn't see how this was going to lead on to, how this was going to get funded and move forward. DFAT and AusAid were kind of combining and their remit was changing, so I wasn't quite sure what the next steps were. So things went quiet for me then. I know David was up in Indonesia at least once more in the interim. But what happened next for me was that suddenly, at least in recollection, that seemed suddenly, DFAT seemed to be interested. We had a series of teleconferences. There was some reshaping of the project, some sharpening of the budget, and shortly before the end of the financial year, indeed, a contract with WHO was sorted out, and the project was formally launched at World AIDS in 2014. So in little under a year, we went from basically nothing to a series of sites that we could work with, a reasonably well-developed project, high-level support from the Ministry of Health in Indonesia, and a fair chunk of funding to get the project done. So even now, I'm not quite sure how it happened. It was just one of those things that David sort of willed, and it did indeed happen. So the study aims was to evaluate interventions to try and increase diagnosis and treatment in key populations in Indonesia. It was basically funded by DFAT and WHO with funding in kind from the Indonesian Ministry of Health and the Kirby Institute. The 4 collaborating sites are led by Prof. Wirawan in Denpasar, Bali, Dr. Rudy in Bandung, Dr. Yanri in Yogyakarta, and Dr. Evie in Jakarta. So you see at the top the full map of the Indonesian archipelago, and our 4 sites are in Java and Bali. Each of the sites is a sort of network with a main treatment site and then usually a series of community health clinics called puskesmas in Indonesia, most of which feed into that main treatment site, or that's the way they typically worked. Those community health clinics doing a lot of the HIV testing and diagnosis. So study design's very simple. It's a simple study. Often the best studies are. So the idea was to recruit newly diagnosed HIV-positive people in these key populations. So the idea was that all newly diagnosed HIV-positive people within the key population would be approached to be recruited into the study, and if they agreed and consented, then we would then monitor all the steps of the HIV cascade through. How they linked to care, when they started treatment, when they were retained in treatment, and what their HIV viral load status was as they progressed. So phase 1 we just called business as usual, and the idea was to see how the current practices were leading to treatment and outcomes in patients, and that would then provide a baseline against which we could compare how some interventions fared. At the same time, during this phase 1, we did quite a lot of work to actually develop the interventions. We did literature reviews, did quite a lot of work with qualitative focus groups with each of the key populations. And much of this work was undertaken by our Indonesian colleagues. And really much of the development of what interventions they thought were needed and appropriate for the systems and problems in Indonesia came out of our Indonesian PIs. So the phase 1 results. So recruitment to March, what I'm presenting here is recruitment to March 2017 with follow-up to September 2017. And in that period, from roughly the end of 2015, so a bit over a year's recruitment and at least 6 months follow-up, we had 831 participants enrolled into the cohort. One of the things we found, which we hadn't expected, was that it was overwhelmingly MSM, 77%, somewhat less female sex workers than we'd expected. We didn't expect a lot of warrior, so that wasn't too much of a surprise, but certainly we had expected more people who injected drugs, and they proved difficult to recruit, at least in part, we think, reflecting changes in the epidemic in Indonesia. And certainly, as in many, this large preponderance of new diagnoses in MSM, I think, is also reflecting of many large urban centres across Southeast Asia. So the mean age, 29 years, with a fair spread, as I say, mostly male, and on the whole, the majority had a reasonably high level of education, so 52% senior high, 23% university. So of those 831, 703 got to a treatment site for a baseline visit. Of those, the mean CD4 count was 272 cells, 36% less than 200, so a reasonably advanced group with 15% who stage 3 and 4. So reasonably late HIV diagnosis in these patients. So this is what our HIV cascade looks in this group. If you concentrate on the overall results on the left, you'll see that of the 831 who were diagnosed and enrolled, it's 84.6? I can't. Yeah, 84. Yeah. So roughly 85% get linked to care, and then 73% start treatment, of whom 55% retained in care, a further decrease in the proportion with a viral load at 6 months, and only 35% suppressed viral load. So if one looks at this as a glass half full results, then this is better than the original HIV cascade I presented, but I think we'd all agree that perhaps there's improvements that can be made. In terms of comparison by the key populations, you'll see that the MSM seem to do slightly better than the other key populations, and the people who inject drugs in particular, as well as being hard to recruit, were particularly difficult to retain in care. In terms of factors associated with increasing the rate of starting treatment, the two key things we found were a higher educational level, but also, importantly and interestingly, if you were diagnosed at a site that couldn't then start treatment, so if you had to go from the diagnosis site, one of the pushkesmas, to the local hospital for treatment, that proved quite a big barrier to treatment, and I think helped inform the interventions that we were interested in doing. So the interventions, these are the 4 interventions that eventually the group came up with, and as I say, largely these came out of the Indonesian teams themselves. And each one of them is aimed at a different step in the treatment cascade. So first of all, can we improve testing and diagnosis? Can we make testing and diagnosis easier for people in Indonesia? And here the idea of using oral self-testing, so oral fluid self-testing, either supervised or unsupervised in their own homes, to make that easier. This was only possible for barley and MSM only, but allows us to get some sense of whether that will improve testing and diagnosis rates. So the second intervention was aimed at improving ART uptake, and it was this idea of having a one-stop shop. So here this idea, this problem where people are diagnosed at a site that can't initiate treatment, that seemed to be a barrier. There are also other barriers to treatment. The need to have, in particular, a CD4 count and a creatinine test before people could initiate treatment seemed to be problematic, involved multiple trips to hospitals for lab tests and so on, and seemed to put people off. So this idea of a one-stop shop where as soon as people got diagnosed, they could be treated at the same site immediately without in particular a creatinine test, and then they would be got back 2 weeks later with the results of that creatinine test, and the idea was that would smooth and accelerate treatment. And this was both in this is in all sites and all key populations. It's at many of the pushkesmas, and also in Yogyakarta, it's at some of the community HIV services in the NGOs and brothels. So to try and improve adherence, the team was interested in using SMS phone messaging, Again, this was all sites and all key populations, and the Bandung side have done a good job in developing the technology that will make this run. So some of you may know the literature, and this sort of SMS phone messaging where you send people reminders or coded messages of reminders to come back to take their pills or to come back to pick up refills. It's had mixed results, I think it's fair to say, but Indonesia, they do love their smartphones in Indonesia, so I think this might be an interesting intervention in this particular area. And finally, in PWIDs only, the Jakarta team have done a lot of work developing this motivational interventional interviewing counselling approach to improve ART and adherence. So here it's a structured program that can be delivered in the same way by non-experts that will hopefully help PWIDs both engage and retain on treatment a group that seemed particularly difficult to retain in care. So the interventions commenced early this year. As I said, developing them took a little bit longer than we'd predicted, so phase 1 went a little bit longer than expected, but recruitment started early this year, and the plan is to continue recruitment through to the end of this year and then have at least a year's follow-up to the end of 2019. And then that will allow us to compare all those steps of the cascade under the interventions with what happened in the sites in the business as usual in phase 1. So next steps, there's going to be, as well as conducting the study, of course, and following up and making sure things run smoothly, there'll need to be a process of developing detailed analysis plans. These studies aren't randomized, and of course there's a number of things going on at the same time, and so exactly how we might evaluate most efficiently which bits of things are working on the cascade will need a bit of detailed planning out. There's also quite a lot of work we need to do planning how we might disseminate these results, both through peer-reviewed publications, but also internally through Indonesia. I am pleased to say that there's a lot of interest in this study in Indonesia, and at our most recent meeting in May, all of the local sub-districts of the health departments had representatives there, and I think there's a lot of interest, and hopefully the results from this could be quite influential in helping to improve treatment and outcomes. In terms of the future, I think HATI has the basis of a good little research network. I know there's InterRespond as well that the Americans are working with, and that overlaps to some extent. But it would be nice to try and keep this going as a network in its own right. They have good data management and analysis skills now, especially through Bandung, so they have many of the technical things. But we've also been able to recruit a few PhD students from these sites who are with us at the Kirby at the moment, so perhaps providing a bit of high-level expertise into the future. And as part of this, we're already beginning to plan the next study. The current HATI study will work through to the end of 2019, and the idea is to have something in place and hopefully funded that we can implement from early 2020 as a way of keeping the HATI team together. So I do want to acknowledge the whole team. It's a big group of people, and they're an interesting and fun group of people to work with. I won't work through all the names, but I do want to highlight our community colleagues. So Ketty Calarina from the Female Sex Worker Alliance, ENS Angela Antono, representing Warrior and gay men, and then Ido, representing the people who inject drugs. They've been very helpful in supporting the project. And finally, just to thank NOTAR, WHO and DFAC colleagues, and quite a number of people at the Kirby who have contributed to this over the years. Thank you.